Secondary Parkinsonism is a result of things that happen to you. Alcoholism can bring it on. Exposure to toxins, which may have been Michael J. Fox. He may have had some kind of toxin situation. Trauma. TBI is a common thing, and people have a lot of, and that's probably what I would say Muhammad Ali did, was have a lot of brain damage from all the boxing that happened in his life. And then Parkinson plus syndromes are multi-system progressive atrophy and progressive supranuclear palsy. And so these are just some things that you see Parkinson's symptoms, but there's some other things going on.
So what is it called whenever they have Parkinson's symptoms, but they don't actually have Parkinson's disease?
I don't know.
But my CI was telling me about that.
Yeah, there's a number of people as they get older, they just will develop some of the Parkinson's symptoms, but they don't have the lack of dopamine. Like they'll have the resting tremor, or they'll, but they're not actually diagnosed with Parkinson's. So I don't know what it's called. But that is actually more common than you think.
I feel like you see that a lot in Alzheimer's.
Yeah, you do see some different things come in with Alzheimer's where you see Parkinson-like things happening with them. Yeah. 3 major symptoms are the progressive resting tremor, the bradykinesis with rigidity, and then the shuffling gait. And that term that y'all need to know with that is festering. A festering gait is where they do this kind of thing. They can't pick up their foot, and so they kind of get going and they start, they're doing their feet like that, and you'll actually see them do that. That's a festering gait. They kind of drag their feet along and they get going and they can't stop. And some other effects of Parkinson's is stoop posture. So that's one thing you're going to address for sure with them. Plopping in chairs is a real common thing with them, so you need to stop that immediately. Once people get in the habit of plopping in chairs, it's very difficult to strengthen that glute again to a point where they don't do that. It doesn't matter if they're your knee patients or anybody. Who plops in chairs, men or women more? No, women. Women just plop right down. I don't know why they do it. But do not that's one thing that you should recognize immediately and start working sit to stand. You do not want them plopping. Why? They're going to break a toilet. They're going to break their bottoms. They're going to, if they fall a whole 6 inches down before they sit down, they're going to eventually hurt something or somebody if they don't break the chair after a while. Well, and with our population being as heavy as it is, that's even more of an issue with furniture, right? So plopping in chairs is really hard on them. Difficulty with swallowing, dysphagia, is a very big thing that happens with them. And so this is when they have to start making some decisions when they get where they can't swallow anymore. So you have to decide as a family and the patient if they're going to go to a stomach tube, a feeding tube. And when they do that, do they want to do that? So there's a lot of life and death decisions that are made with some of these patients, by the way. And that is probably the biggest one, going to a feeding tube. Then if they can't swallow, what's going to happen to them if you don't do that?
They're going to starve.
They're going to die. Monotone speech to no speech is what we were talking about with excuse me 1 minute. Difficulty with swallowing, again, is where you kind of do start making those decisions. Monotone speech to no speech, and so this is again where that big started. When they open their mouth big, they teach them to really put out a lot of air and that kind of thing. They do have pain in their joints. Why?
Because they're older.
When you're older and you're stiff, you just stiffness just causes more pain in joints.
Does it not hurt to like just keep moving all the time?
Yeah, they need to keep moving. It's really true for anybody, right? It doesn't matter what patient you have. If you have a rheumatoid arthritic patient, if they quit moving and go to bed, they're gonna die in a lot of more pain than if they keep moving. People always need to move, it doesn't matter how old they are. And if they make a decision to go to bed, they're gonna die. You just can't, you gotta keep moving. So that's really true for any of the patients. They do have constipation because those muscles are also affected. The autonomic nervous system muscles are affected, the involuntary. Probably the biggest thing that happens with them is the mask-like expression. And why is that such a big deal? I don't know, we're all wearing masks. I guess it's, we still just look at people's eyes, don't we? But their faces, they always look like they're not happy. I mean, it's just a blah, and so it's very difficult you have to make yourself realize that that's not the person that you're talking to in there, is what you see on their face. And so that's really one of the hardest things, is that mask-like expression. They have visual degeneration, and also some of them have dementia. Sometimes dementia does go with that. But I don't have that one in
My
there.
grandpa has Parkinson's and he gets like hallucinations sometimes.
That hallucination stuff actually comes with medication.
Yeah.
And so I think the biggest thing that you need to do is educate them on that. Is he aware that that's what causes that?
I don't think so.
You need to tell him. Does he have a lot of dementia, or
No. Well,
who am I looking at?
right here.
Talk to me first.
Yeah.
You're freaking me out, Ms. Robinson.
I
was not
really
singing
looking
off
over there.
there.
No, but I've noticed, because he'd be calling my mom and he would ask her how the boys would be, and he's talking about my brothers, but he doesn't remember the names.
Mhm.
So I don't know if
That would be more dementia, but is he seeing them?
I don't know how to describe it. It's different.
You need to tell him that that's what that is. Because, well, let me tell you this one situation that it was kind of neat to be a part of it. I had a friend whose dad had Parkinson's, and he had moved from Dallas to Poto because he had Parkinson's, and he was seeing hallucinations.
Yeah.
And he had just lost his wife, and so he thought he was losing his mind, quite frankly. And I knew that it was caused by medication, the medication they give them. And so he said, "Do you see those little boys out there?" And I said, "No." And he said, "I'm seeing things." And he said, "That's why I moved here." He said, "It's never scary. It's always children, but I see children all over the place, behind trees, hiding, all over the place." And so we started talking about it, and I told him that it was his medication, and I treated him for about 2 months, and then he moved back to Dallas because he didn't think he was losing his mind. So no one had ever told him that. And I want y'all to think about that. How important is it for them to know that their medication is making them hallucinate? You need to tell him.
He does the CBD oil because he's got bad tremors, but I mean it helps him a little bit. It calms him down a little bit. I think that's why he likes it the most.
Yeah, well, anything that makes him more comfortable
Mm-hmm.
is good. But anyway, just be aware of that. That is something that you can, they do have hallucinations, and usually it's connected to the medication they're on, and it can really affect them. So,
The medication that causes that, is that something like they have to have?
yeah, it's the L-Dopa stuff that they have to have to decrease the rigidity and stuff. They can try some different parts of it though to see if they can switch it and make it better, but overall they just tell them, well, it was interesting, I have a Parkinson's patient I'm working with right now, and we were talking about it, and she said she's also never been scared. Like, it was never a scary hallucination, it was good people. That's what she says. I see people in my yard all the time, but I'm never scared. They're just people in my yard. So we talked about that. And so it's just kind of, and it's nice that it's not a scary thing to them. they just think they're losing their mind, you know? So I don't know, I would tell him, you know, just to make him, just to see ask him what he sees.
Yeah.
And it'd be interesting if he actually sees your brothers, or if he sees some other kids, you know, or
Yeah.
something like that. I don't know.
I wonder if they look like you could tell they're hallucinations, or if what if he just goes and talks to people and they're not real?
Well, both instances where I've dealt with it, and even this lady the other day, she lives right next, over by one of the Assembly of God churches, and she sees those people out in that parking lot all the time. And she asked me, we were walking out there in the front yard, she said, do you see those people in that parking lot? And I said, no. And so, you know, that's when we started talking about it. So, I don't know. I think it's good that it's not a scary hallucination.
It's crazy that your mind, though, can make up something that's not there. Like, you see it, but it's not there.
Well, it is, and the medication causes it. So think about how drugs affect you anyway, sometimes.
My great grandma got bad for a while, and some kind of medicine she was taking made her hallucinate to see her dead husband. It was a little weird.
That's a
I thought
little
it was-
scary,
it was
yeah.
time for her, but she's better now. She doesn't take that medicine anymore. But it was a
Yeah,
little
I mean,
scary.
if they don't have to have it, you wanna get them off of anything
Yeah.
that caused that kind of mental, I mean, that's very scary.
That'd be hard.
Yeah, because think about how it just would affect your overall affect, especially if they were a fearful thing like that. Did she know her husband was dead and that?
No, she thought he was back. I was like, no, he's not. I'm sorry.
Yeah, and that's hard, because then
Yeah.
sometimes they forget that they died.
Yeah, but she's better now. I mean, she's not taking that medicine anymore.
Good.
So with Alzheimer's, is it the medication that they take that makes them think of things, or is it just the disease?
It's pretty much the disease of Alzheimer's. Yeah, it's, they have that deterioration, and they lose all those neurons in their brain.
We thought it was that at first, but then we checked with the doctors and it was the medicine.
I would always check on medication.
Yeah.
How many meds do they have to take before they're interacting, for sure?
4 or
7. And I have patients that are on 15. So if you're taking 7, is it 4? Is that what you're telling me? 'Cause you're
Well,
on 7?
actually, 4 is for balance. I was getting them mixed up,
Yeah.
but
I don't know, I've just read that before, that for sure, if they're taking 7 medications, they're interacting with each other. But, well, and you probably see people with 21 medications.
oh yeah.
Crazy, people taking all those pills. Do I think that's good? I don't. I think we need to look at that. But people do what their doctors tell them to do. I'm not gonna look at it because I can't, right? But I do think if you have a grandparent that's taking that many medications, you need to find a doctor that you trust, or a pharmacist, and look at really what they're taking and make sure that, because sometimes you'll have 3 or 4 different doctors giving them this medication. So that's just something to think about. Treatment is usually an L-Dopa product or a Cinemat. You know of any others? So that's pretty much medication-wise, it's been the same for years. They have upped the dose to where they give a lot more of it initially, where they used to just build it up. But a lot of doctors now will bombard them at the beginning with quite a bit more medication. PT treatment is the big program. And if you end up doing, you guys who are going to Baptist, you will see the big program, because they do it there and they're trained in it. Possibly Mercy, I don't think anybody's trained on it, but I may be wrong. Did anybody see it? Did you see it?
She told me about it, but I didn't see it in action. But I'm pretty sure she said the guy that came up with it had Parkinson's.
Really? I don't know. It could be, yeah. You want to keep them as ambulatory as long as possible. I've been known to walk somebody with Parkinson's with one person on both sides. I try to get family members just to walk them around the block. You gotta hold them up to walk them, but walk them. They need to walk. Keep as mobile as possible. There's basically just a good strengthening program in supine is good because they lose their ability to roll. And so doing a lot of range of motion, bridges, knee rolls, straight leg raises, all kinds of lower extremity strengthening is good for them. You need to work on them rolling in bed and lifting their hip. We'll talk about that, but when you guys, when Becky comes to do the kids, when you roll over in bed, do you stay, what do y'all do as soon as you roll over, do you think? You pick your hip up and roll. Did y'all ever thought about that? Parkinson's patients lose that ability so that they can't get comfortable on their side. So you have to work on them rolling over and then picking that hip up to turn. So we'll talk about that some more as we get into rehab. A stationary bicycle is good, balance exercises and general conditioning just to keep them in good health. One of the things that a friend of mine did is she spent a lot of money for it, she had Parkinson's, and it was a bicycle that was a stationary bicycle that she sat on, but it moved for her. So she turned it on and it moved for her. She put her legs in there and she would ride it for 30 minutes. So it moved her feet and then it did her hands like this. So she got on it every morning and it did the movement for her. She said, and she had already had Parkinson's probably for about 4 or 5 years and was still ambulatory, still able to take, but just was starting to lose some where she was afraid she was going to get bad. And she got that bicycle and it really helped her. So she was a believer in it. It was way too expensive. She paid a lot of money for it, but it really helped her. So just, to do something that moves for them actually kind of loosens them up. And so she would go with it after she first got started in the morning, but it would get rid of all that stiffness in the morning for her. So it was a real effective thing for her. A lot of general conditioning because they just get where they sit around and they get depressed, don't they? So it really makes a big difference in that area. Probably as far as some of the posture, I should have posture on here too, is because of this, one of the things that I usually do a lot with my Parkinson's patients is I do a lot of them just laying flat in the bed and stretching their arms with a stick overhead and putting a weight on it and just stretching their arms back, just to kind of stretch them out because they lose that ability to do that. I would tell y'all to realize that supine exercises are not bad, okay? You go into a lot of clinics and they don't utilize them, but just be aware that people have to be able to move in bed. And you have a lot of control when they're in bed. When they're flat, you've got a lot of stabilization. So, I do almost all of my shoulder range of motion flat because I want that stabilized. So I would tell you that there's nothing wrong with doing bed mobility exercises in a home program. You need to do that. I think I've told you that I've had people come home from rehab that couldn't get in and out of bed. That's crazy. It's because they're not treating them in supine.
I have a question about home health.
Okay.
Have you ever had a patient where they need more treatments throughout the week, but Medicare only approves them for maybe once a week? Have you ever gone out there pro bono and helped them?
I do that. I have
you
done
know
that.
that, they need
I'm not doing
money?
anybody. Deanna and I used to do a lot of pro bono stuff, but we don't do as much. Remember, when you guys do pro bono, though, you have to have a PT involved. You cannot legally do that on your license. So you have to have a PT involved. So sometimes Deanna will call me and say, I have this patient, and she'll probably end up going and seeing that spinal cord patient if she gets cut off. But, so I've done evals for her so she can continue treating. But yeah, I do pro bono stuff. But you can't do everybody, it kind of has to fit in your own life. But you can legally do it, and if you ever do it, you want to make sure and write your notes. You're still, remember that that's when you have to have liability insurance away from your job because they're not paying your liability insurance. So I carry part-time liability every year. That's away from Pearl Albert and any other place I'm working. So my home health cover me. but I always carry 24 hours worth of part-time liability, just because I do a lot of things like that.
How do you get that?
It's, through Health HPSO. You guys, last time, my husband's not working anymore, but last time I paid for his, it was $83 a year. That's pretty cheap. I would encourage you to have liability, even if your company covers you, I would still, because for $81 a year, if something happens and you're treating a family member or something, or if you treat a friend and something happens, you are covered. If it's only through your work, you're not covered. Does that make sense? I mean, if it wasn't a work-related type patient, then you're not covered. So I would encourage you to carry liability. Okay, so there's our Parkinson's. Any questions on Parkinson? Okay, amyotrophic lateral sclerosis. ALS, has anybody dealt with ALS? One summer when I was doing home health, I had 3 female ALS patients that I worked with in this area. It's a horrible disease. It's also called Lou Gehrig's disease. Who is Lou Gehrig? He was a baseball player that had it, and he was a very famous baseball player, and he died pretty quickly after he got it, didn't he? But that's years ago, so they didn't have as much to save them. It is a chronic terminal neurological disease. Death normally occurs in 3 to 5 years after onset of symptoms. And a lot of whether they die or not depends on if they're willing to go on a ventilator. Interestingly enough, ALS patients normally do not go on ventilators, and they just allow themselves to die. So all of a sudden they just quit breathing and they go. That's been my experience.
What did Stephen Hawking have?
He had a type of ALS, and but it wasn't like a typical, but that's what he had.
Okay.
Because he lived like 40 years, didn't he, with it? I have worked with a guy who, they normally, but they're the people who go on ventilators, and he was on a ventilator. But anyway, that's what he had, but it wasn't a typical ALS.
The time frame was way different than typical.
Yeah, he came down with it though fairly young, didn't he?
Yeah, it's in college.
He was in college, but he lived pretty.
He had like a few kids and everything like after he was diagnosed too.
He went ahead.
Died fairly recently.
Yeah, it wasn't.
But I think he had it for a while before he had to go on the ventilator.
Yeah, it wasn't a typical ALS progression, is what I think. Weakness is noted distally first and then moves proximally. So they start having their fingers, they can't function, they start dropping things, and they have foot drop. So their feet, that's when they usually notice it, is when they start stumbling. Atrophy of muscles of hands, forearms, and legs due to degeneration of neurons in the ventral horn of the spinal cord. So this is where you actually see the swiggly things that go through the muscle. And it's basically in the muscles. The cranial nerves affected are the hypoglossal, trigeminal, facial, and so you have a lot of swallowing and tongue problems. It's usually diagnosed with an EMG, so you're looking for fasciculations, and that's where you see that going through. That means the muscle's dying. And a decreased nerve firing in the distal muscles first, and then it moves up finally to the diaphragm. And that's when they have to decide whether to go on a ventilator or not.
Why is it those three? Is there any reason why it's those three?
No, it's just what you see with it. I don't think there's any real reason. I don't know. Occurs usually at 50 to 60 years of age. mainly what I did with the patients that I had that summer is, one of the ladies was just getting where she couldn't walk. She was still working, she was in a power wheelchair most of the day, she was still working 4 hours a day. And so, for her to be able to function and her husband not have to stay home with her, she had to be able to transfer from her bed to, well, she had to be able to do a toilet transfer by herself independently, so she wouldn't have to have someone stay home with her. So we got a sliding board and she was able to do that, and I think she worked up until the time she died, which was real interesting. And then I had one lady, and I went in and did a complete evaluation for her, and we went in and redid the whole bathroom, and that was with her. So you don't really do a lot of strengthening with them because they're just deteriorating, but mainly that's what you do. How do you make them more functional? How do you figure out ways to keep them going as long? Sometimes you go in and you order them a power wheelchair. So that kind of thing. So that's kind of how I'm not sure how much y'all would even deal with it. Because again, you're not going to do strengthening. You're going to go in and say, we got to widen the doors so they can get the wheelchair through. We need them to where they can be able to transfer to the toilet.
What's some like out of the box things